Thank you so much for joining us for our Friday Huddle call. Going to give another minute for folks to get in, and then we can get started. Okay, it looks like we've got everybody in the room who came into the waiting room. So here we go. So my name is Margie Beaudry. On behalf of Trust for America's Health, I'm very pleased to welcome you to our third week of Huddle calls to discuss challenges and solutions for ensuring access to COVID-19 vaccines for older adults and people with disabilities who cannot leave their homes. This session is being recorded so that we can capture all the ideas and experiences shared. This call series is part of an initiative to identify and foster adoption of innovative and promising practices on this topic. This work is made possible through the generous support of the John A. Hartford Foundation, which works tirelessly to improve care for older adults, and the Cambia Health Foundation, which is dedicated to improving the way people experience healthcare. Access to the COVID-19 vaccine for older adults is being prioritized across the country due to the vulnerability to more serious illness from the virus among this population. However, for the estimated 15 million older adults and individuals with disabilities who do not leave their homes, access is challenging or impossible. These challenges are not well understood, but the government agencies are beginning to attend to these challenges as the vaccine supply increases. Many jurisdictions are still challenged in identifying who needs a vaccine administered in the home, and state and local governments must compile lists from multiple sources. And there are additional complexities with the increased numbers of certified vaccinators and variations in stabilizing the supply of 3 different vaccines that may be used for home visits. Vaccinating this population is made even more challenging because of the crazy quilt of definitions, vaccination policies, reimbursement difficulties, and workforce needs, not to mention cultural and language barriers that must be overcome to vaccinate this population. But state and local health departments across the country, working in partnership with the Aging Network, hospital systems, and other community partners, are turning their attention to this population, and a variety of innovative and practical solutions are emerging. Throughout this call, please use the chat function to share challenges, lessons being learned, and opportunities to improve vaccine access. In studying this topic, we are seeing some themes emerge. Over the course of this call series, we expect to touch on each of these themes from various perspectives. We're all learning together at this critical moment. These huddle calls are designed to share just-in-time or just learned information as broadly as possible. Today's discussion is focused on the particular needs of veterans who are homebound and how best to meet those needs. I'm very pleased to welcome Tom Eads from the VA. He will share observations and insights about the current state of practice, as well as what is needed to effectively deliver vaccines to veterans in the home. And then we'll open it up for questions and discussion. Tom, turn it over to you.
Great. I really appreciate this huddle, the opportunity to get together and learn from each other. And I'm going to sort of frame this in the context of reaching beyond our walls to provide a bit about the VA in-home vaccination experience, but I'm really eager to get into a discussion. I thought I'll cover these points. I'll provide a little overview of the VA experience in our VA home-based primary care program, a few of the challenges that we encountered, some of the logistical issues and solutions, how our creative folks came up with solutions to some of those. I think a question that's come up in prior huddles, how do we identify a population that warrants in-home vaccination, and get into some discussion on potential partners. A little bit about VA home-based primary care program. It is complementary to and very different from Medicare home care. Home-based primary care is comprehensive, meaning we're going to take care of all the problems that this person may have, this person with serious, complex, chronic disease. It's longitudinal. We feel that most of the time, the reasons we bring you into home-based primary care do not get better. So we're likely to be providers for your care very often until the end of life. We do discharge people from home-based primary care, but for many of them, this is really the best option to help them remain safely in their homes. It's delivered in the home by an interdisciplinary team, and that includes a physician, medical director, primary care provider, which can be a physician, nurse practitioner, physician assistant, nurses, social workers, rehabilitation therapists, dietitians, pharmacists. I'm really proud that since 2006, we've had a mental health provider as part of every home-based primary care team. We target individuals who have complex, serious chronic disabling conditions. And this is really for when routine clinic-based care is not effective. We'll often say for those who are too sick to go to clinic. And I got that in a conversation with Joanne Lynn, so thank you, Joanne, for that. Really helpful communication, I think, piece about that. So, but there, we don't have an age cutoff. Anyone who has had prior military service and is a veteran enrolled in the VA system for care, we welcome you into this program. The average age, however, is I think upwards of, it's about 77 years old. So we have some younger veterans with serious neurologic conditions. Most of these are fairly older individuals. We are providing care to about, and they have on average 8 medical conditions and on average more than 12 medications, and that's after we've worked really hard to pare down their medications. So it's a pretty a challenging group, and they face the challenges of remaining at home. We're providing care to about 60,000 veterans a year. Our current census is about 34,000. That's just a little bit less than it had been prior to the pandemic, so we've pretty well maintained. We have added some people, but not a lot. We've had less enrollment into home-based primary care over the past year, a little bit less. We have home-based primary care programs in every medical center in the VA, about 500 of our community-based outpatient clinics, and several reservations. Some of the logistical challenges, I'll say from, back a year ago, right? COVID starts to emerge, and there were conversations in VA about prioritization. There was a lot of prioritization for hospital and for emergency department, appropriately so. There were conversations about where are we going to get the staff to meet the needs in the hospital and the emergency department. So those staff were being reallocated, appropriately so. There were questions about, well, maybe our home-based primary care programs, where they're not going to be providing home care anymore, so let's pull them into the clinics. Reasonable conversation. We, several of us brought forward some reasons to maintain that workforce, maybe with some modifications. We're all ready to change what we did, change different, practices. This is a different time, a different setting. We have to adjust to. But we felt like there was a very strong reason to maintain a workforce meeting the care needs of this very vulnerable population. As we pointed out, and I think we all recognize this, as a nation, we, and I include VA in that, we initially may not have paid enough attention to those in nursing facilities. And we quickly woke up to that. And in VA, I think we did a really remarkable job of then quickly modifying the practices in that setting. But it became very clear this is a very high-risk population in our nursing facilities. The patients we're taking care of in home-based primary care and similar populations that you're all taking care of really have the same profile. They're at the same risk of serious consequences of COVID if they get it. There's a difference in traffic and exposure, but we really, that helped frame that. Some of the challenges that we encountered, like, okay, well, how are we going to get, you can't do this. We can't take vaccines into the homes. We haven't done that before. We've done that before in lots of vaccines, but not COVID, right? So there were those concerns and temperature control and timing, and we must not waste any. So there were lots of conversations around that. Our medical center leadership and the home-based primary care teams and the pharmacy departments, I'm really proud that they all worked that out. And so they worked out a lot of the logistical challenges. Who's going to make these? How are we going to train them as vaccinators? How are we going to do it safely? What equipment are they going to have with them? How are they going to transport this safely? What's our process to go from the pharmacy to the home? How are we going to make sure we don't waste vaccines? So those kind of things were worked out quite smoothly, and progressively we increased the vaccination program in home. That began really right in the beginning of February. By mid-February, I think I have my numbers right here in front of me. I think by mid-February, we had vaccinated about a third of our home-based primary care patients. And as of just a few days ago, we had vaccinated nearly 60% of the veterans in home-based primary care. And over a third of veterans in home-based primary care have had their second vaccination. So I'd consider this really a very successful rollout to a substantial number of veterans. I think I want to quickly then pivot. I want to have lots of time for discussion. I want to quickly pivot to how do we, some of the things I think, thinking beyond VA, how do we identify these individuals, right? So I think there are a number of ways to consider that. We can think about, and I think Steve Landers addressed some of this earlier this week, who are the agencies? Who's getting home care currently from any source? Who's recently received home care? Who's in Medicaid? We reach into some of our county health departments and some of our area agencies on aging. Can we have Meals on Wheels? Can we have conversations, help identify those folks who interface with the homebound population? And then the potential partners, and something we've been thinking about, and I'll just say that we have a program for intermediate care technicians. That's the VA term for former military medics and corpsmen. They've done a lot of things in the military involving healthcare and in very difficult situations. And but we use some of them for vaccinators. They're providing in a number of very important roles for us, but this is one of them. So that's an option. I also was thinking about this, and it came up in the question on earlier this week about what about the National Guard and the reserves. And so I've talked with some folks. I'm in the Department of Veterans Affairs. That is not the Department of Defense. So we really do not have any jurisdiction over over the National Guard or the reserves, but the state governors have some role in that. So I've talked with some folks who are in that military medic and Department of Defense and who have some experience in that area. And so they said, yes, this is, the governors have an option. The National Guard tends to be under the state management. So that is a conversation that I think is also to be considered. One other thing I wanted to point out, and that's our practices in VA. They did them a little bit differently. Some, at least initially, sent out 2 people. There are some reasons to do that. Many of our sites move toward 1. And, obviously, it's more expensive to send 2. But many of our sites then felt very comfortable sending 1 person. That seems to work very well. They're prepared. They have the EpiPen. They have their telephone. They can call for help if they need it. And then they also do some routine home visit work while they're there. And I'll just say that for a lot of folks, the question of 1 vaccine or a dual dose vaccine, we have found it also helpful in this time. It's not it seems like a good use of resources to go back and see somebody a month later in this situation. The social isolation, the conditions that may decline a bit without notification. We know that a lot of people out there have been reluctant to seek medical help. So I'll stop there. Any questions?
So, wow, Tom, I'll jump in, and we do have some questions that will, prompt things, but certainly questions for you. I guess I'm still reeling a little bit from your 60% number. I think there are a lot of folks out there who wish that their numbers looked like that for their, the percentage of homebound folks who who are vaccinated. And clearly there's some infrastructure that you all had in place in order to, that you could leverage in order to get there. But I'm sure folks on the line are interested in understanding the pieces that were in place that got you there, because a lot of folks are going to want to try and emulate what you've done.
I should clarify, that doesn't mean that 60% of them got the vaccine in the home. That's 60% in home-based primary care. Some of them had some other opportunities. And so we absolutely try to optimize those as well. Some of them, for whatever reasons, were getting in to see medical care. That's not a lot of them, but I just, we did try to use every possible resource for getting vaccinations in place.
Of course, of course. So let's open it up for some questions. If you want to put a question in the chat, or if you want to raise your hand, that's fine. Oh, we do have a question from Maggie Orenstein. Maggie, you want to just unmute and go ahead?
Hi, thanks for the presentation. 60% is a very impressive number. I'm advocating for family caregivers to be included in vaccination. I know that you all do that, I think. Can you speak to that a little bit?
That is such an important issue, and we have pushed, we have a legislative barrier to that. We have the authority to provide care, and that includes vaccinations to veterans, but with few exceptions, we do not have the authority to provide such care to non-veterans. Congress has been very responsive to our discussions about this, and they're actively putting something in place that would open up that authority. So it's a really hugely important for practical reasons. Why would you, think about this as part of the conversation we've had, like, would you vaccinate your nursing home residents and not vaccinate the staff? Would not make much sense. So the same thing here. These are the family caregivers taking care. So you get why it's a challenge. We're doing that in some for whom we have authority, and we're pushing for the authority, efficiency, and just plain the right thing to do.
When you say authority,
maybe we can create partnerships. That's another thing we've been pushing on a little bit. Can we create a partnership like we have with Indian Health Service?
Can I just follow up? When you say authority, do you mean that caregivers are eligible because of age or for other reasons, not as caregivers? Is that what? No, there's a
family caregiver program in VA that has, for veterans who are seriously injured, there is a program in which we incorporate them into the care. They get benefits, they get a stipend, they are covered. But the great majority of veterans, their family members are not covered.
Thank you.
Margie, I have a question. Tom, this is Megan at TIFA. I'm just curious about whether your homebound population, whether there's been hesitancy, and if the visits that they receive from your primary care, clinics and personnel, because they are familiar with them, do you think that has helped with hesitancy? So if you could just address that issue.
Yeah, thank you. Some of us have had some conversation, a little feeling like, well, hesitancy is a very gentle and fine term. We at least want to make sure we prefer not to label people as vaccine hesitant. They have some maybe concerns, they have uncertainty, vaccination uncertainty. Any way you call it, though. Yes, and I'm really pleased. I took a look into some of our first home-based primary care sites, and they, on average, had 77%, some as high as 85% vaccination success rate. So that's a pretty high rate of acceptance. And I think, and a big part of I think what we're all learning, right, is there's an education barrier. So informing people, and particularly informing them from a trusted position, someone they trust. So we have, in part of that logistics is some scripts for conversations for the staff to use, for the administrative staff to use if somebody calls in and has questions. And that generally allays most of the concerns that people have.
Okay, thank you.
The American Academy of Home Care Medicine and the CDC both have fact sheets and information sheets that are really helpful in that.
I'm curious if others on the line have been interacting at all with veterans in your communities, and particularly those who are at home, and if you've been partnering at all with the efforts that Tom has been describing. Sorry, question from Noah Levine. Are the scripts publicly available?
Yes, I'll make sure I get them to this group. So,
thank you,
Margie and Megan.
Yeah, and then we can make sure to pass that on. Other questions?
On the vaccination uncertainty and that trusted source, I want to appreciate that every one of you are taking care of veterans. About 1 in 5 Americans over the age of 65 are veterans, and a substantial proportion of veterans choose to receive their health care from someplace other than the VA. So you're all taking care of veterans, and very often veterans have an immediate trust and bond with other veterans. So if you are able to identify someone on your staff who's a veteran, that might be helpful in being a person that might make have some of the conversations, particularly with people who have significant concerns or questions before they accept a vaccination.
Such a great suggestion, and fairly easy to implement, I would imagine.
And it goes along with all the, the efforts of all of you to have your outreach group mirror the culture and ethnicity of the population you're serving.
Tom, Megan again, while we're waiting for others to think of their questions. One of the suggestions that, that we've had from one of our colleagues with regard to this whole process is the importance of leadership in establishing someone within the jurisdiction who can really take hold of the issue of ensuring vaccine access for those who are homebound, and seeing it through from strategizing to delivery and so forth. And so within the Veterans Administration, of course, you have your system, and you're a leader and you have other leaders. But for those jurisdictions who don't have that kind of system already in place, what suggestions would you have for who should take the lead there? I mean, I think there are some cities, some counties, some states who, they're still not sure, should it be aging, should it be public health, should it be the providers? There's still, should it be the home-based providers? There's still a lot of discussion about who should take the lead.
Yeah, I'm much more comfortable sort of just a conversation about garnering leadership support, but assigning who would take responsibility. I guess for all of us, there's a sense of urgency, whether you're deciding upon to use 2-dose vaccine or one. My position on that one is get it out there, whatever you have, as quickly as possible. And the logistics of, like the Pfizer vaccine, 6 hours after it's in a syringe, generally that could be room temperature. That works fine for in-home vaccination. So, and the second vaccination is not generally a big issue. So you make decisions like that, but finding out, I guess you need a champion, right? You need a champion who's going to come up with some of the information that's been put together through this series of what makes this group particularly at risk. What are the consequences of not vaccinating them, both to them as individuals and their family members, as well as to the health system when they come in a serious condition to the emergency department and hospital, the impact of all of that vaccinations can have. And I think people in our experience with that information, the leadership generally then recognizes and appreciates having that information. then who in the community would lead that. It's just such an important time to work together. And that's probably going to be very, very location specific. I don't know, have others had an experience in their community that these are the folks that stepped forward and led the way in our community?
I think everyone's eating their lunch.
I mean, I appreciate this opportunity. I wanted to, I thought VA might be in, maybe further along than some, and that I think this sets a pretty good tone of like, is this possible? Yes. Is it possible on a large scale? Yes. Is it possible to do this in, in a month period of time? We can do a lot in a month. And so those answers, I think this helps answer. And then it's how do we make that happen in different systems?
Yeah. Yeah, it's actually a great case example of how to take existing infrastructure and use it for a new purpose. And clearly you have some economies of scale because of that infrastructure. But I agree. I think there are lessons here that a lot of folks can take away and customize. Terry, you want to open up your phone and ask your question?
Sure, Tom, thank you for that presentation. It's just always inspiring to hear how the VA moves out quickly and all hands on deck. So Tom, in your view, how could our country be more coordinated as a whole next time? We know the VA is doing good work, ACL is doing good work, CDC is doing good work, but it isn't clear to me that people are coordinated. What's your view?
I agree, Terry, that we could do a better job of coordination. And I think some folks, a lot of people have put a lot of efforts in, and there are a lot of things that did get coordinated. I think we could be better prepared, and I think interagency, looping in who are the potential partners, and I think there's a lesson here for being better prepared. There's a role for the federal partners. There's a role for the state and county partners, and how do we? And ultimately, it's going to happen best when all of that is really well coordinated. I think we've seen that some of that coordination is less than ideal coordination has led to some delays.
Yep.
And so there are opportunities for improvement. And I do feel like there are just so many that have a really important role in this, and they all have the same goal. So, I hope that we will reflect on that and be better prepared.
We have a vaccine czar now in the White House, and that's Dr. Boucher, who was Commissioner of Health in Chicago, and then he was at Kaiser, and now he's in that role. I think that's the first time we've had a vaccine czar. Tom, correct me if I'm wrong, but that might be a way forward. And anybody else who knows anything about that, I welcome any chat in so that we can learn from you.
Yeah, I think a central point of coordination, that just makes so much sense and could pull together the federal agencies, the state, the county.
Absolutely. So I'm noting the time. And so Tom, we want to thank you so much for taking this time with us. Tom does have some slides. And so when we send out the recording and the slides from today, we will add the slides in that Tom was talking off of, so that you will be able to have those as well. And I'll just look forward to next week. We are continuing to host these 30-minute huddle calls Wednesdays and Fridays on topics related to the COVID-19 vaccine for those who are homebound. Our next call is on Wednesday, the 24th of March. And our featured speaker will be Robin Lipson from the Massachusetts Executive Office of Elder Affairs. I am putting, as always, the links for the registrations into the chat. Just a heads up for our April series, we will continue, but there will be a different method of registering, hopefully an easier one than this one proved to be. So we'll look forward to sharing all that with you via email. And I want to thank everybody here for all that you are doing, and we will hopefully see you very soon.
Thank you.